They have three unique features that we don't see elsewhere. There are the tennae coli, which are three bands of longitudinal smooth muscle in the muscularis. That creates or helps create hostra, which are pocket-like sacs caused by the muscle tone of tennae coli. And there are epipeliotic appendages, which are fat-filled pouches of visceral peritoneum. The large intestine is divided into the cecum, which is the first part. Coming close off that first part is the appendix, which is a mass of lymphoid tissue, part of the mucosal-associated lymph tissue of the immune system. It is a bacterial storehouse that is capable of recolonizing the gut when that becomes necessary. Unfortunately, that twisted shape of the appendix makes it susceptible to blockages. You may have heard at some point the appendix was not needed, and it is not needed, but it's not just a vestigial organ. It does have a purpose. We have the colon, in which there are several regions, most of which are retroperitoneal. The transverse and sigmoid regions are not. The colon is divided into the ascending colon, which travels up the right side of the abdominal cavity to the left of the right kidney. It ends in a right angle turn, and that is anatomically known as the right colic flexure or right hepatic flexure. The transverse colon is going to run across the abdominal cavity. It will have another right angle turn, and this one is known as the left colic flexure or splenic flexure. The descending colon would then travel down the left side of the abdominal cavity, and part of the descending colon includes the sigmoid colon, which is an S-shaped portion that travels through the pelvis, and then the rectum, and there are three rectal valves that stop feces from being passed with gas, flatulence. The anal canal is the last segment of the large intestine. It opens to the body exterior at the anus, and here there are two sphincters, an internal anal sphincter and an external anal sphincter. The internal anal sphincter is composed of smooth muscle. We do not have conscious control over it. The external is skeletal muscle, so we do have conscious control over that. The cecum, appendix, and rectum are all retroperitoneal. The colon is retroperitoneal except for its transverse and sigmoid parts. The intraperitoneal regions are anchored to the posterior abdominal wall by mesentery sheets, and those sheets are called mesocolons. And here we have a dissected specimen, an artist's rendering. And this is a good view of the large intestines. We have the ascending, transverse, and descending colons. And a different angle, different cut. Appendicitis is an acute inflammation of the appendix, usually results from blockage by feces that trap infectious bacteria. Most common in adolescence, and that's when the entrance to the appendix is at its widest. There's venous drainage that can be impaired. That leads to ischemia and necrosis, which is tissue death. A ruptured appendix can cause peritonitis, an inflammation of the peritoneum. Symptoms of appendicitis would include pain in the umbilical region, moving to the lower right abdominal quadrant. That would be accompanied probably with loss of appetite, nausea, and vomiting in many cases. The treatment is a surgical removal, an appendectomy, or in some cases treatment with antibiotics. This is one of those surgeries that goes back and forth between commonplace and less commonplace. Nowadays they often try to treat the acute appendicitis with antibiotics and then make a determination as to whether it needs to be removed. Large intestines contain thicker mucosa that's made up of simple columnar epithelium, except in the anal canal, and there it becomes stratified epithelium because there's a lot more abrasion going on. It doesn't contain circular folds, villi, or digestive secretions. Its contents are have abundant deep crypts with many mucus-producing goblet cells. Mucosa of the anal canal hangs in long ridges or folds referred to as anal columns. The anal recess is located between the anal columns that secretes mucus to aid in emptying. There's a structure called the pectinate line, which is a horizontal line that parallels the anal sinuses. Visceral sensory nerves innervate the superior part of that line. Its region is insensitive to pain, while somatic nerves innervate the lower part of the line, and that would be sensitive to pain. Superficial venous plexuses of the anal canal are what become hemorrhoids when they get inflamed. The bacteria in the large intestines consists of at least 1,000 different types of bacteria. There are at least 10 bacteria cells in your body for every one human cell. It enters the small intestine or the anus to colonize the colon. And they have very important metabolic functions. One of those functions is fermentation. So they help to ferment indigestible carbohydrates and mucins. That, unfortunately, as a product of that, releases acids and gas, approximately 500 milliliters a day. They are important for synthesizing vitamins. They B complex vitamins and vitamin K needed for the liver to produce clotting factors. Beneficial bacteria outnumber and suppress pathogenic bacteria. The immune system helps to destroy any bacteria that get across the mucosal barrier. Epithelial cells will recruit dendritic cells to the mucosa, and they sample microbial agents and present them to T cells of the MALT system, and that triggers the production of IgA antibodies that restrict the microbes. Mounting evidence does show that the kinds of bacteria that are present are very important. They have at least an association with body weight, susceptibility to various diseases, and moods. And it may be possible to manipulate gut bacteria in the future, and that may be part of a healthcare strategy for things such as body weight, susceptibility to diseases, and moods. Antibiotic-associated diarrhea accounts for about 14,000 deaths per year. C. difficile is an anaerobic bacteria that many have in our intestines, and that is the most common cause, so that when antibiotics wipe out other bacteria, the C. difficile, which is resistant, more resistant, can flourish and cause pseudomembranous colitis, which is an inflammation of the colon. And that can also lead to bowel perforation and sepsis. C. difficile infections are resistant to many antibiotics, therefore they are difficult to treat. People have been experimenting with fecal transplants, trying to repopulate the gut with healthy bacteria, and that would suppress the C. difficile. Residue remains in the large intestines for about 12 to 24 hours. We don't get food breakdown except for what the bacteria digest. We do get vitamins made by the bacterial flora. Water and electrolytes are reclaimed. That is a major function of the large intestines. And most of its job is to propel feces toward the anus and allow for defecation. Large intestines is very important for our comfort, but it is not an essential organ. If the colon is removed, the terminal ileum can be brought out through the abdominal wall, and the patient would have what is known as an ileostomy. We get a lot of movement in the large intestines, and that includes haustral contractions. These are the most of the contractions of the colon, where haustra are sequentially contracted in response to distension. So we get slow segmented movements, mostly in the ascending and transverse colon. There is the gastrocolic reflex, which is initiated by the presence of food in the stomach. That results in mass movements, which are slow but powerful peristaltic waves that activated 3 to 4 times per day. and the descending colon and the sigmoid colon act as storage reservoirs. Low fiber diets can narrow the colon and cause strong contractions that increase pressure on the walls. That can result in diverticuli or herniations of mucosa. Diverticulosis is the presence of diverticuli. It is common in the sigmoid colon, and it does affect half of people over the age of 70. Diverticulitis is an inflammation of a diverticuli, and those can rupture and leak into the peritoneal cavity, perhaps being life-threatening, causing peritonitis. Irritable bowel syndrome is a functional GI disorder. Symptoms include abdominal pain, stool changes, bloating, flatulence, nausea, depression. Stress is a common precipitating factor, and stress management is important for the treatment of irritable bowel syndrome. Defecation is the mass movement that forces feces toward the rectum. Distension will initiate a spinal defecation reflex under parasympathetic signals to stimulate the contraction of the sigmoid colon and rectum. They will then relax the internal and anal sphincter, and then conscious control will allow the relaxation of the external anal sphincter. Muscles in the rectum will contract to expel the feces, and that is assisted by Valsalva's maneuver, in which we've gone over before, but you close the epiglottis, contract the diaphragm and the abdominal wall muscles, increasing intra-abdominal pressure. And then the levator ani muscles contract, causing the anal canal to be lifted superior and allowing the feces to leave the body. So this is a spinal reflex. Impulses can come down from the cerebral cortex for conscious control, voluntary motor nerve to the external fibers, open that, and then we have when stretch occurs in the sigmoid colon, it sends a message here to sensory neurons, and that sends the reflexive action to get it as far as here. Then this is going to walk you through each one of those. Sensory. Move the food forward to the rectum. Consciously open the external anal sphincter, and defecation occurs. So clinical homeostatic imbalances, diarrhea is presence of watery stools that would result when the large intestines doesn't have sufficient time to absorb the remaining water. Could be caused by irritation of the colon by bacteria or jostling of digestive viscera. That can occur in marathon runners, for example. Prolonged diarrhea might result in dehydration, and electrolytes will follow water, so that would include electrolyte imbalances, including acidosis and loss of potassium. The other side of that coin is constipation, and that can occur when food remains in the colon for extended period of time and too much water is absorbed. In that case, the stool would become hard and difficult to pass. That can be a side effect of insufficient fiber or fluid in the diet, improper bowel habits, and lack of exercise or abuse of laxatives. And I will cut it there, and we'll finish up with physiology of digestion and absorption. How do we get materials from our food into our circulatory system?